Good morning, students. Today it is a very interesting topic. That is the most common condition we encounter in our clinical practice. Either when you are entering a hospital or when you are a full-fledged doctor seeing patients, most common complaint that what we see: body pains, fever, breathlessness, kind of those things. So today we are going to discuss among these three most common is fever. Patients do tell that I have got normal fever, but there is no such thing as a normal. Any fever is abnormal. So today topic is about fever. I would like to simplify, though it is very vast, because except God, no one knows about medicine completely, even your professor of medicine. So the aim of this presentation is to make you comfortable, and whenever patient comes, quickly diagnose the patient condition. So today topic is about, as we have discussed, that is fever. So fever, another term for fever is pyrexia. Pyrexia means pyros. Pyros means fire. Nowadays, anybody who has got ambitious kind of those things, they are called firebrands. But here this fire is dangerous. The word fire has become the synonymous with fever. So here the Greek terminology for fire is pyros, Pyros. As we discussed in the previous section, many of our medical terminologies have been derived from either Greek and Latin. So we have to bear with those things. So fever is synonymous with pyrexia. So coming to what is normal temperature. Most of the times, either during your childhood or when you are in current postings, you might have seen temperatures being taken at various sites, from axilla, from oral, sometimes from our forehead, sometimes over, we can say, tympanic membrane, and also in very rarely in ICU settings, esophageal temperatures, rectal temperatures. So among these, most common used and standardized is oral temperature, taking temperature from the oral cavity. So the normal temperature of oral cavity in a biggest study is 97.7 to 99.5 degrees Fahrenheit. Why I am telling Fahrenheit is because in India it is common thing to use Fahrenheit rather than centigrade. But for your sake, I am telling that there is simple easy conversion formula. 1 degree Fahrenheit is equal to centigrade plus 1.8 plus 32. You can remember easily like this. At the age of 18 years, you enter the college. By 32, you start practicing. So you can remember like this. If you want to convert from centigrade to Fahrenheit, because these are two different parameters, you can remember this formula, but with practice, it will come automatically. The oral temperature, as I mentioned, it is 97.7 to 99.5 degrees Fahrenheit as of currently. Whatever other ranges that have been are outdated, though I advise you to not to remember these things, means rote learning. As you practice, automatically should come. Nobody outside exams are going to ask what is the normal range, except there are some variations that I am going to tell. So according to the study and consensus, any temperature falling outside, that is 99.5 or more than that, means at 100 degrees Fahrenheit, it is known as fever. So ideally, temperature should be documented at least twice, measured twice, so that it can be corroborated with good thermometer. But remember, for everything in our nature, there is a variation. Variation according to the day, variation according to the month, variation according to the seasons of the year. When we take temperature of any person, in mornings it will be the usually lowest, say at around 8 o'clock. By the time it slightly increases. Why this happens? Any guess? Usually, just like for temperature, for many things we have got diurnal rhythms regulated by suprachiasmatic nucleus located in brain. So what it does, it regulates so many genes known as clock genes. So this happens for a reason. You know one hormone that is known as glucocorticoid, cortisol. This cortisol peak comes in early morning hours. Because it is a glucocorticoid, it suppresses so many inflammatory markers or cytokines. So temperature will be little bit lower side in mornings, whereas the cortisol hormone slowly comes down. So those inflammatory markers or whatever we call cytokines, they will be little bit higher in evening timings. So by evening, temperature will be slightly higher because of the increase in these inflammatory markers. So that is about the diurnal variation. So coming to monthly variation, usually you know better than me that women start menstruating from the age of 13 to 15 years. Menstrual cycle is divided into two halves. First one is proliferative phase, second one is secretory phase. So these two phases are differentiated by a process known as ovulation, where ovum is released from the ovary and it enters the fallopian tubes. So during ovulation, there will be slight rise in the temperature. That happens because of the thermogenic hormone known as progesterone. Progesterone. So this hormone causes little bit elevation of the basal body temperature by around 1 degrees Fahrenheit. So in previous olden days, doctors used to find out before advent of ultrasound by daily measuring a woman's temperature in morning hours. If there is increase in the temperature by around 1 degrees Fahrenheit, they used to document as ovulation. And you may ask for how long this temperature persists. Throughout during that luteal phase, as long as this progesterone hormone acts. So it again comes back to previous state when that lady starts menstruating. And another variation of our body temperature is seasonal. Because of heat and humidity, our body temperatures are slightly lower in summers. So if you measure the temperature in summers, it will be slightly lower by around say around 5 degrees Fahrenheit. On other hand, in winters, down the northern pole, to compensate for the heat loss, especially in winter months, there are two types of thermogenesis. Shivering type thermogenesis because of muscle contraction like this. Second one is non-shivering thermogenesis. So non-shivering thermogenesis usually happens from our internal organs like liver, kidney, kind of those things. They compensate by increasing the body temperature. So that's why there is a slightly higher temperature as far as we humans are concerned, especially during winter months. So that is the basic concept of fever, definition and variation. Hope you understood this point. So we'll come back to other variations which during second year of MBBS or even final year may not be necessary, but these are little bit advanced topics which might be interesting those who have passed out MBBS and preparing for PG entrance. That's why I earmarked in this box. The first one is for every decade as we age, our body temperature comes down. How much? 0.02 degrees centigrade. And similar thing happens with hypothyroidism. Hypothyroidism means lowered body temperature, though it is not hypothermia, it is slightly lower by around 0.01 to 0.02 degrees centigrade. So these two one can keep in mind. On other hand, if you see any cancer patients, their body always feels little bit feverish, but it is not fever because of release of cytokines and various other toxic products from the tumor cells or infections. So in any cancer patients, even without fever, the basal temperatures increases by 0.02 degrees centigrade. So in a aged, say 70-year-old person, if you are finding increasing temperature day in and out, suspect cancer unless proved otherwise. There are other, as we discussed earlier, other sites of measuring temperature. As we told, first one is oral, which is the most commonly employed. Second one is auxiliary, which is not recommended, but unfortunately we do in India. Other temperatures what we do are core temperature, especially for esophageal, at the level of lower esophageal sphincter, which is done in ICU settings, and tympanic membrane. Though tympanic membrane has been touted as one of the best sites, the problem is there are two variations: unadjusted temperature and adjusted temperature. If a temperature sensitive thermometer, which is meant for tympanic membrane, if it is unadjusted, it will give gross lower values. Even the patient is having fever, it may show patient doesn't have fever. You can see the value is lower by almost 1.6 degrees Fahrenheit. That's why nowadays it is not recommended at all. So this latest teaching is in contrast to other old teachings which you might be reading. So what I meant is that we have to update our knowledge constantly. So that's why we have always been discussing about updating our knowledge constantly and always pursue what is new. Learning a new point every day enriches our life and makes us authentic, not some pseudo expert. Basic points we'd like to tell about being a good doctor is he or he should have number 1 availability, number 2 attitude, number 3 authenticity. So 3 A's you can remember. One is availability, second one is attitude, third one is authenticity. However you are good are at subjects, how many gold medals you have got, whatever it is there, it doesn't matter as long as you are not available to your patients, because patients have got lot many choices. So you should make yourself available to the patients. Spend as much time as possible with them. Try to learn from them, because learning is a two-way process. It is not one way. Please remember that thing. Second one is attitude. Attitude means conducting yourself. As we age, by experience, we learn that our attitude also changes. So in initial phases, we might be thinking we know each and everything on the earth. So if you are showing attitude, definitely that means it is a negative tone. It is going to reflect upon your success. There is one adage that as you age in the life, you should give more value to the others. So value is a two-way street. That means when you are giving value, you will receive value. That is the most important thing. So conducting, how you conduct yourself is the one of the most important thing. So as a doctor, because you are just novice in medical profession, the most important thing for success, not only medical field, for any other field, say for engineering, for commerce, anything, here in our profession, but what we say our customers is, in our profession, we don't call our patients as customers, though actually it has become a, we can say, commercialization. So as you enter our medical field at the age of 16 years and passing out after MBBS, and again we had to do some specialty, in majority of the cases MD or MS, further specialty, or some people migrating overseas. Wherever you are, 3 points I would like to tell that are, you can say, prime factors for our success. Number 1 is availability. Availability to our patients. Any business you take, the business has to be available. If you are simply sitting at home, that means whatever you are doing is futile. That means you have learned swimming but you are not going to sea at all. Second one is attitude. Attitude, it is not a permanent fixture. It changes as we gain experience. So as we learn better of ourselves, better of our environment, and of the depth of our subject, more we become humble. So most of the times this communication is two-way when you are discussing with patients or patient attenders or with your colleagues. Please remember, learning is always a two-way process. Not only you are learning, they are also learning about you. So they are going to judge what is your attitude, whether you are really understanding what they are trying to tell, so that you will arrive at correct point, means we can say diagnosis. Third one is authenticity. What is meant by authentic? Author. So author means an expert in that subject. An expert is a person who knows himself that he doesn't know much about in his subject. That means as we learn more and more, we will come to know that what we know is very little. You can descriptively say what we know is just a drop in a ocean. And down the line, if you recapitulate or refresh your memory after 30 years, whatever you have learnt now lays just a basic foundation. On top of that, you have to build your career by learning more about this subject on daily basis, because science is ever changing and concepts are ever changing. If we are going to stick to grand old habits, most of the times we will become outdated within 1 or 2 years. So advise, as you are young children, please have these 3 A's. One is availability for your patients. Second one is your attitude, which you have to refresh more frequently than necessary. And last but not least important is being authentic. So authentic actually makes us humble. If someone is arrogant, shouts and arguing, that means he is not authentic. Please remember, whoever it might be. Coming back to our topic of fever, there are 2 interesting things that we have to know. To make the subject more complicated, some people have found out that any fever crossing 106, you can see even up to 107 or more than that. In grand olden days, they used to think that it is because of infection. It might be, but most common cause is CNS problem, not infection. All fevers are not due to infections. There are many insults, irrespective of infectious causes, they can lead to rise in body temperature. Among them, one of the most important things is CNS lesions, especially stroke. An elderly male or female becoming unconscious, seizures, weakness. If you do CT or MRI, you will find out either infarction or hemorrhage, blood. So these local insults within the CNS can lead to rise of temperature. It is not because of infection, please remember. And sometimes it can exceed this 107. Here the issue is that the hypothalamus is still active, but hypothalamus is like a center, which is like a, you can say, thermostat in winter climate. So if you increase the thermostat set point, the room temperature also increases. So there are many triggering points for this thermostat, not only microbes. There are many other things, inflammatory markers, which can increase the set point of that thermostat. The thermostat is here in our hypothalamus. So the local insult like any infarction, hemorrhage, tumor sometimes can lead to hyperpyrexia. Here the body temperature is very, very high. So the point is immediately you should cool down the patient, because here the hypothalamus is still active. There is a role for antipyretics. What antipyretics you know? Most of the times they are known as NSAIDs, non-steroidal anti-inflammatory drugs. Non-steroidal, so no steroid anti-inflammatory drugs. So among them you know aspirin, ibuprofen, kind of those things. And you also know one more agent that is most commonly what we use, known as paracetamol, which is known as acetaminophen in Western world. So most commonly prescribed drug is paracetamol. So during fever or in hyperpyrexia, our paracetamol will act. But on the other hand, there is one entity known as hyperthermia. What is this hyperthermia? Here hypothalamus is not reset. Here the problem is the outside heat raises our body temperature so much that even this hypothalamus can't regulate that thing. It often happens in summer months, especially down south. Nowadays Hyderabad is witnessing temperatures of around 46, 47. At this time, if a person goes out, especially an elderly person who is having comorbidities like diabetes, hypertension and taking multiple drugs which interfere with sweating, so the core body temperature increases uncontrollably. So the patient may develop dehydration if he neglects nausea, vomiting. Sometimes he will end up in coma or even death also. So that is known as heat stroke. Here the catch is that even though temperature increased, here there is no problem in hypothalamus. Here the problem is in increase in the core body temperature. So in heat stroke there is no role for any paracetamol kind of those things. Immediate cooling by other methods is most important as far as heat stroke is concerned. So far we have discussed about fever. So how fever is produced in a person? Whenever this hypothalamus is reset, there is vasoconstriction of peripheries. Say hands, legs, they feel cold and clammy because blood supply is diverted to vital organs. So what are vital organs? Heart, kidneys, brain. But nowadays because of a brain might not be that vital organ. Yeah. Coming to second compensatory mechanism, that is shivering. So shivering, a person with a temperature especially shivers like this. So in shivering what you are feeling is muscle contractions. So muscle contractions, you know, they produce a lot of ATP. So that will also lead to increase in the core body temperature. Clear? First one is redirection or redistribution of blood flow from peripheries to vital organs. That is the fundamental physiological adaptation for fever. Second one is, as I just told, muscle contractions which produces lot of ATP. And third one is non-shivering thermogenesis. There are some vital organs. What are they? Which produces lot of, which got lot of mitochondria, liver, kidneys. Especially liver, it can lead to heat generation. Got the point? In spite of absence of shivering, a person can develop increased body temperature, especially from the liver. So liver is the primary organ responsible for non-shivering thermogenesis. If you tell this point, your professor will be more than happy. He may reward you with a chocolate or not, I don't know, but this is one of the important things. Last one is behavioral changes. Whenever you might have seen so many times, if your classmate or your friend or your parents or someone else having fever, what they do? They want to simply lie down and have a blanket so that they don't want to lose. It is behavioral adaptation. Whatever the temperature that is there, that will be retained. If you switch on AC, they will shiver again. That means they want a little bit warmer room, even hot room, where you feel quite uncomfortable on other hand. So here the body adaptation is because of the resetting of our hypothalamus in the brain. Got the point? On other hand, I have told you two things. Fever and hyperpyrexia, hypothalamus is reset. Whereas in heat stroke, that is also known as hyperthermia, that is increase in the core body temperature because of the outside heat. So this is the point. I hope you are clear. So we have come to know the basic how fever happens. So what are those cellular pathways which can lead to fever? Either they might be exotoxins or endotoxins. As we have just told, all fevers are not due to infections. They can be due to tumors, they can be due to vascular disorders, they can be due to endocrine disorders, kind of those things. Either whether they are exotoxins, means outside, or endotoxins, sometimes we can call as super antigens as far as gram positive bacteria is concerned. Okay, we will gloss over those things because they are little bit advanced topics. Whatever toxins, whether produced outside or within the body, so they are going to stimulate the host cells. What are those usual host cells? Endothelial cells, other reticular endothelial RES system, from where we will get the host responses. So they release cytokines to compensate for these toxins, to inhibit their detrimental actions. Cytokines. So what cytokines you know? If you ask this, even I also don't know. There might be hundreds of cytokines, but most important are just only 3. I will tell what are they: interleukin 1, interleukin 6, and tumor necrosis factor. That's it. If you remember these things, it is more than sufficient. Interleukin 1, interleukin 6, tumor necrosis factor alpha, TNF alpha. Here interleukin 1 is the primary, and it enhances the production of interleukin 6, which is the most potent pyrogenic cytokine. You know what are cytokines? Cytokines are nothing but small proteins, around 10 to 20 kilodaltons, produced by most of our host cells. So these are just proteins. So coming back to our concept of pathogenesis, these cytokines in the bloodstream, they beautifully enter the brain, and especially at the level of hypothalamus. Again and again I am telling, this hypothalamus is the one of the, you can say, master point or master of the brain, because with most of our day-to-day activities it is related. Earlier as we discussed, day-to-day variations, our waking up, sleep, appetite, kind of those things, behavior, everything is regulated by hypothalamus. Hypo means below, thalamus. So it is structure located below the thalamus. That's why it is known as hypothalamus, and it is closely related to pituitary. There is one beautiful axis known as hypothalamo-pituitary axis, where hormones from the hypothalamus regulate the pituitary hormones, that we are going to discuss in the endocrine section. So hypothalamus is the center which regulates most of our vital functions as far as human body is concerned. In hypothalamus, what the cytokines do is that they trigger the release of production of prostaglandin E2 from the please tell from where this prostaglandin comes. In the biochemistry, you have already studied that prostaglandins are derived from the cell wall membranes, especially from the arachidonic acid. So the precursor is arachidonic acid, and by action of phospholipase A2, kind of those things. So what will happen? Synthesis of prostaglandins do happen. There are many classes of prostaglandins, but relevant to our topic, most important is prostaglandin E class. Among these, again subtype is 2, prostaglandin E2. Though it is number 2, it is one of the most important things as far as pathogenesis of fever is concerned. So the locally produced prostaglandin E2 directly is not going to cause the fever. It further enhances the production of cyclic AMP. Though cyclic AMP is the final endpoint, the cyclic AMP causes the resetting of the thermostat. So it is clear: toxins, cytokines, prostaglandins, cyclic AMP. So 4 things. These are the elements which are involved in the pathogenesis of the fever. So this finally, the function of cyclic AMP is it upregulates the hypothalamus. That means rather than the sensing the normal temperature, hypothalamus sensing of ambient temperature increases, just like a thermostat in our houses, especially in winter season. Also there is a concept that because here prostaglandin is locally produced, there are also peripheral production of prostaglandins in the setting of fever. or sometimes this prostaglandin E2 may leak from the blood-brain barrier. So, this prostaglandin E2, it is not only responsible for fever, it is also responsible for many of the things, causative factor for behavioral changes or those things which patients suffer from when they are having fever, like body pains, especially myalgias, arthralgias. Myalgias are nothing but muscle pains, arthralgias are nothing but pain involving the joints, either large joints or small joints. But it is not arthritis. Remember, there is a difference between arthralgia and arthritis. Arthralgia means algia, pain, that is it. Itis means inflammation. In some settings, there might be inflammation of the joints in the absence of fever, like common variety, our rheumatoid arthritis. But here, these symptoms are transient as long as fever is there, either myalgia or arthralgia. Hope it is clear. So, dear students, we will come to penultimate part of our discussion about fever. So, this is how to approach a patient. In previous video also about breathlessness, that is dyspnea, I told how much it is important. History. Second thing is physical examination. For example, if you are given 30 minutes to elicit history and physical examination of a patient, spend at least 3/4 of that time with history. 3/4 of time means 75% of time, approximately 20 minutes, and remaining 10 minutes is for physical examination. Unless you are arrived at provisional diagnosis, also we call it as probable diagnosis, by at the end of history taking, that means it is incomplete, there is something missing. So, physical examination is going to add, or it is going to give only corroborative findings, whatever you have got that view on history, whether the patient has got infection or something other like connective tissue diseases, or something others like aging, endocrine diseases, or some CNS insult, which are the most common causes of fever. So, history is important. Never ask leading questions. Let the patient talk. If at all you feel the topic is getting diverted, then you can ask, specifically tell more about your fever. That's all. Again, patient may switch back to his mode towards what the current problem he or she has got. So, history, when you are taking, active listening is the most important. Time. Whether it is happening in morning or evening. Changes means fluctuations. Is it relieved by antipyretics like paracetamol? Okay. Any other changes he or she has got, that all we should elicit. But the catch is that every patient who is having fever is not going to show outside manifestations, especially in extremes of age, like newborns, in grand old elders, say more than 75 years of age, those patients on cancer chemotherapies. And another interesting for advanced is those patients who are receiving glucocorticoids, GC, glucocorticoids, steroids, because they are going to suppress this production of prostaglandins, that prostaglandin E2 what we had discussed already. And another one is those patients who are receiving anti-cytokine therapies, anti-cytokine. So, what are those cytokines which are responsible for fever? Interleukin 1, 6 and tumor necrosis factor alpha. If these same cytokines are responsible, say for arthritis kind of those things, if at all it happens that the patient gets monoclonal antibodies for various conditions, they are going to blend the response, that is body thermogenesis. So, take care that drug history and their age we have to keep in mind. Got the point? Fine. Let's go back to what we have to do. You have taken very good history and you have done very perfect physical examination where the patient might be or might not be having a rash or any other end of those things. Because in most of the times, physical examination, even if it is cursory, it is not going to reveal anything except myalgias and arthralgias. In very few cases, rash either might be because of viruses or because of the drugs, kind of those things. So, fever approach, it consists of history, physical examination, and third one is doing basic labs. Don't order whatever available test on the earth, just like few labs which does everything for every condition. Even if go for routine health checkup also, they do testosterone hormone in female and cancer test in a young person who just goes for cold and cough. It is not this so. As a doctor, we have to be very judicious in our approach, means cost effective approach, which is required, which is unwanted. In that setting, if the patient is a young male or elderly male or the patient is having any background diseases, all these things one has to keep in mind. Okay? So, let us go back to labs. The basic test what we order is known as hemogram or CBP. These are essentially interchangeable terms. CBP means complete blood count along with peripheral smear. But nowadays, grossly neglected thing is peripheral smear, examination of the peripheral smear. That what we have learnt in our physiology classes, but unfortunately, experience is the most important thing as far as interpretation of the peripheral smear is concerned. Second one is their intuition, their clinical judgment, their expertise. So, there are very few pathologists who rightly give peripheral smear report. Otherwise, sometimes machine will give peripheral smear report which sometimes doesn't match with clinical picture at all. For example, patient might be having thrombocytopenia, machine count might be showing spuriously high values and vice versa also. So, in such settings, whatever you have seen on history and physical examination, cursory physical examination, that is the most important thing. If there is mismatch between labs and your history taking, repeat those labs. Never blindly trust. Okay. So, in hemogram, what we are going to see, all those blood elements which you have learned in physiology, RBCs, WBCs, platelets, kind of those things. What are relevant to our WBCs? White blood cells or leukocytes. In infections, there is shift to left. Shift to left means immature forms are seen. Because of the increased demand to counteract these either exotoxins or endotoxins, our body tries to compensate by overproducing these WBCs. So, in that hurried process, sometimes immature forms also get released, like band forms. And another one is dole bodies. What are dole bodies? These are nothing but physiological aggregates of rough endoplasmic reticulum, where WBC is yet to mature, but in this accelerated process, they are getting released. So, dole bodies. Second one is toxic granulations, toxic granules. These are not toxic, actually they are nothing but our azurophilic granules, primary granules. They contain a lot of enzymes which are necessary for microbicidal action. So, these are the exaggerated physiological changes. And third one is cytoplasmic vacuolation of WBC, cytoplasmic vacuolation. Means in this hurried process, sometimes there will be phagocytosis by the cells themselves. So, you might be seeing some vacuoles in the cytoplasm of WBCs. So, these three, presence of dole antibodies because of accumulated endoplasmic reticulum, toxic granules because of the nothing but they are azurophilic granules, third one is cytoplasmic vacuoles. These three are known as toxic triad. Toxic triad. which suggests the patient is having some incinerating infection, which we have to aggressively pursue and treat. So far we have discussed about shift to left and toxic triad that you can remember if at all it is required to impress during examinations. But practical also it is useful when you start practicing, when you want to read peripheral smear, because nowadays what happens is that most physicians they just gloss over these peripheral smear reports. It's okay, thrombocytopenia, kind of those things. But shift to left, especially in the setting of fever, those patients who are on cancer chemotherapies, it will be useful if you discuss with pathologist. So the importance of peripheral smear is always throughout our lives. Never neglect this part. And other things which are important as far as CBP is concerned is inflammatory markers. Here our cytokines, you may ask the question, why we can't measure cytokines? Interleukin 1, 6, kind of those things. Yes, we can measure, but they are quite costly and they are fleeting also, means very transient elevations are there. On other hand, those effects, after effects of there are much more marked. So what are they? Direct markers and indirect markers. One is ESR that we have learnt in physiology. Second one is C-reactive protein. So these are acute phase reactants. If you wish, we can discuss more about these inflammatory markers in separate class, because it almost takes at least 30 minutes to come to know about these inflammatory markers, CRP and ESR. But for brevity, I am telling what we measure routinely are these two only. And among these, if you ask which one is preferred, CRP is preferred, because long after resolution of infection or inflammation, ESR will be elevated for months together. And there are many confounders like arthritis, some other diseases, which can lead to persistent elevation of ESR in the absence of fever or infection. There is a lot of confusion about CRP. So what are they? Usual CRP and another one is hs-CRP. But please remember again and again, both are same. They are measuring the same molecule. But why we call hs-CRP is because this is known as high sensitivity CRP. H high, S sensitivity. So if you see this thing, any value less than 0.3, that falls under the banner of hs-CRP. Clear? Anything more than 0.3, that is our routine CRP. You might be wondering why this classification. One is what we are measuring with hs-CRP is known as microinflammation, which is especially relevant to cardiologists. You know nowadays this inflammatory concept, because of our change in habits, modern lifestyle, and there is a subtle release of or excessive production of cytokines. Same thing, interleukin 1, 6, tumor necrosis factor alpha, but they may not cause the elevation of CRP to the extent of 0.3. On other hand, but there is a problem with them. Even if they are subtly elevated, say 0.1 to 0.3, please remember units are milligram per deciliter. Milligram per deciliter. It can lead to increased cardiovascular morbidity and mortality. So that's why this is one of the important topics for cardiologists and other physicians who are dealing with geriatrics like endocrinologists, nephrologists and physicians. So less than 0.1 is known as low grade inflammation. Fine, okay. 0.1 to 0.3 is average. This is also one of the risk factors. This is clinically significant inflammation as far as cardiovascular adverse effects are concerned. Clear? So, this hs-CRP essentially deals with low or microinflammation. On other hand, any value more than 0.3, please remember units, milligram per deciliter. Always it is good practice to mention units when you are writing or labeling, because there are so many variations, milligram per liter kind of those things. Here, just for our convenience sake, I have been discussing only in this milligram per deciliter. So, from 0.31 it is mild. More than 1, definitely there is some problem here body. If it is more than 5 milligram per deciliter, it indicates patient might be in sepsis. So, whenever you see a patient with a fever with a CRP of between 1 to 5 milligram per deciliter, definitely he or she is having problem. Most probably it might be bacterial, or sometimes severe viral also can lead, and especially if it is more than 5, suspect a bacterial infection unless proved otherwise. Clear? So, this is known as macroinflammation. But I stress again, what we are measuring is the same, though assays are different, means the test methods are different. What we are measuring is CRP only. There is no separate thing like hs-CRP separately, CRP separately. Just like some people mistake for albumin and versus microalbumin. They think that albumin is different and microalbumin is different. Both are measuring the same thing. What microalbumin measure is the just like hs-CRP, it is measuring the lower levels of albumin in the urine, which corroborates with the kidney damage. So, if our concepts are clear, we will be a good physician. Okay? So, students, coming to the final section about treatment. Actually, in grand olden days, there was a notion that whether we actually treat fever or not, because at that time scientists used to think that fever itself is a body physiological response to any insult, either exogenous insult or endogenous insult. So, their thinking was that whenever there is a high grade fever, at that time these microbial products or whatever those harmful substances, they will die because they won't survive at that temperature. So, body tries to increase the temperature to counteract these harmful bacteria or viruses. But current concept is, in spite of temperature, our body defense mechanism is not so effective. On other hand, this increased body temperature leads to some unwanted side effects, especially water loss, increased respiratory rate, kind of those things. One thing is that for every 1 degree centigrade increase in the temperature, water loss is around 100 to 300 ml per day. So, please remember, whenever you are treating a patient with fever, give extra fluid unless there are other contraindications. And second thing is that each 1 degree centigrade in temperature can lead to increased respiratory rate by around 13%, which can sometimes lead to respiratory failure in already those patients who are suffering lung issues like COPD, chronic obstructive pulmonary disease, or any heart issues where body may not compensate. So, in such settings, the current paradigm is to treat the fever irrespective of the whatever notion previous doctors used to think. So, what treatment we have to give? That you know, paracetamol in most of the times, except in few settings where we give aspirin, ibuprofen, where we feel that fever is not adequately responding to paracetamol and patient is rapidly decompensating. Coming to second one, okay, types of findings that we have to look for during treatment. First one is Sphygmothermal dissociation. Have you ever heard of this term? Sphygmothermal dissociation. This is nothing but relative bradycardia. Relative brady means slow. Cardia, heart rate. According to Liebermeister rule, for every degree rise in Fahrenheit, our heart rate should rise by at least 5 beats per minute. So, if you convert into centigrade, for every 1 degree centigrade, at least 10 to 15 beats per minute we have to anticipate. On other hand, if the patient is having increasing temperature, but pulse rate is not that going up much, in spite of say from 80, it should go to 90, whether it is around 85, you have to suspect few conditions. It is also known as Faget sign in the honor of that doctor at New Louisiana who used to diagnose yellow fever, where astute documentation of clinical records is must. He used to observe pulse, BP, temperature and meticulously document. Actually, it was the legacy of yellow fever. Later, this sign has been extrapolated to other diseases which can lead to relative bradycardia. Why this happens, that we have to know. Usually, along with the fever, our heart rate should increase as a compensatory measure. But why it is not increasing? There are many theories that I am not going to tell. Most important is cytokine mismatch. On one side, as we have seen earlier, pro-inflammatory cytokines, interleukin 1, 6, tumor necrosis factor also increasing. On the other hand, there are regulatory cytokines, which might be compensating for this cytokine storm. So, this is the one notion. Second one is bacterial toxins themselves or viral toxins. They are directly suppressing the chronotropic effect of the heart, means decreased heart rate. Third one is endotoxins, especially from the liver. They might be decreasing the heart rate. So, whatever is the plausible explanation, in some conditions, especially those bacteria or viruses which are intracellular, we can see relative bradycardia. Most famous example is enteric fever or typhoid fever. So, in typhoid fever, we will find this pulse temperature dissociation. Sphygmo is term for pulse. So, in these conditions, fever doesn't obey Liebermeister rule. Okay, got the point? So, what are other conditions which can lead to relative bradycardia, especially intracellular? Just assume brucella, leptospira, sometimes drug fever also can cause relative bradycardia. So, in addition to famous example of yellow fever and enteric fever, there is a mnemonic for those organisms which can cause relative bradycardia. This is MLC. M is mycoplasma. C, these are all intracellular bacteria. They can lead to atypical respiratory infections. So, in community acquired pneumonia, if you have got relative bradycardia, suspect these organisms: mycoplasma, Legionella pneumophila, third one is chlamydia, cetuxi, kind of those things. So, MLC, these are atypical respiratory triad. So, in respiratory infections, if you are witnessing relative bradycardia, suspect these organisms. This will be helpful especially in your advanced exams. So, let us go back to other types of fever. Tertian fever, Tertian fever, that means fever happening on every other day, means alternate day. In olden days, they used to count every day as a fever, means that is an inclusive method. For example, fever is happening on first day, there is no fever on second day, but on third day, fever is happening. So, this is known as Tertian fever. On other hand, first day there is fever, second and third day no fever, fourth day fever happens, it is known as Quartan fever. So, when anti-malarials were not available, especially in 18th century, 19th century, this pattern of fever used to give to a clue to which type of malarial infection this patient might have got. In this tertian kind of those things, these are either vivax or falciparum kind of those things, whereas in Quartan fever, it is Plasmodium malariae. So, tertian means third. So, every third day, that is inclusive method, not exclusive method. First day is also counted. First day, second day, third day. If fever happens on third day, it is a tertian. If it happens on the fourth day, it is Quartan. Clear? Let's discuss about Pel-Ebsteins. Who are these guys? So, who are these Pel and Ebstein? One is Dutch, another one is a German doctor. So, they found out this typical fever pattern in lymphomas, especially in Hodgkin's lymphoma. So, in their honor, this is labeled as Pel-Ebstein fever. A person, especially a elderly male or female, having fever for continuous 3 days to 1 week, and again after a gap of 1 or 2 weeks, again having fever for 1 more week. That means we can easily remember like this: 1 week fever, no fever for next 1 or 2 weeks, and again having fever on third week. So, this is a type of intermittent fever. So, why it is happening? In such patients, they observed that the patients have got some organomegalies and anemias, and they have got lymphadenopathies, especially cervical lymphadenopathy, kind of those things. So, lymphadenopathy, splenomegaly, and initially before the wording of lymphoma, they called it as pseudoleukemia. Pseudoleukemia, because in those days only blood cancer that is known to everyone was leukemia, and here the abnormal blood component is of lymph nodes. After that, they labeled it as lymphoma, and this is known as Hodgkin's lymphoma. Hodgkin's. Is it specific to that? Not so. But the theory is that just like in other intermittent fevers or recurrent fevers, in Pel-Ebstein fever also, initially these tumor cells will release a lot of cytokines for 1 week. After that, these cytokines burden gets exhausted, because after all cells also have to manufacture. Second component is body will take over regulatory mechanisms. So, whenever body controls these tumors, then they do not have fever. That may last for next 1 or 2 weeks. And again, when tumor enlarges, it starts to release cytokines, leading to fever either on second week or third week. So, this intermittent characteristic feature was characteristic of Pel-Ebstein's fever. Got the point? Where you encounter this term Epstein? Any guess? Any condition related to heart, especially right ventricle? Good. You got the point. That is Epstein anomaly. Means atrialization of right ventricle, finally leading to tricuspid regurgitation. We will discuss the topic whenever we come to cardiovascular system. Okay, let's go back. So penultimate one is periodic fevers. So what are those periodic fevers? They are also intermittent. They also might be called relapsing fevers, but periodic fevers are entirely different concept. Most common known one is familial Mediterranean fever, and second one is familial Hibernian fever. These are of two entities. These are also known as autoinflammatory diseases. These are all fall under the spectrum of our common known things, which are known as Still's disease, gout, polychondritis, in that spectrum. And last one, just for completion sake, what I am telling is quotidian. What is quotidian? Around the day. If fever happens every day, it might be mix up of other microorganisms, especially in the setting of malaria. Especially if fever happens every day, one has to suspect co-infection of falciparum and vivax. Next slide. There are various classes of or we can say classification of fever pattern according to number of authors. Everybody has got his whims and fancies without realizing the basics of the fever. So finally what happened is students got confused. Especially to simplify subject, one has to be expert. So when you are expert in your field, in latter part of your life, your students should adore you for simplifying teaching. So I am trying to emulate that as far as my efforts are concerned. We can broadly divide into fevers into two types. Recurrent fever, which also can be called as relapsing fever, happening for a few days, then patient feels okay, no fever, again fever coming back. Second one is continuous fever. So intermittent fever, recurrent fever, these are of one category. Continuous fever, where some others put a arbitrary cutoff of less than 1.5 degrees Fahrenheit fluctuation, they label it as continuous fever. Happens in usually typical toxic situations like severe pneumonia, brain infection, that is inflammation of meningitis, especially bacterial meningitis, and enteric fever, which is quite severe. So also they put a arbitrary cutoff of double that of 3 degrees Fahrenheit. Fluctuations are there, but they never touch the baseline. So according to them, continuous fever, it never touches the baseline. Here fluctuation is there, but here also the temperature never touches the baseline. And attribution is for those intracellular organisms, especially Rickettsia, Brucella, and one of the dreaded complications of heart, infective endocarditis. That means infection of the walls of the cardiac cavity. Either it can be mitral wall or tricuspid wall. Especially in intravenous abusers, we have to keep in mind of infective endocarditis, especially of right heart. Okay? Okay, let's go back to this one, recurrent fevers. In addition to infections, there are some other uncommon causes which you encounter as your practice expands, either in autoimmunity or autoinflammatory conditions. So what are common autoimmune conditions that you encounter other than hypothyroidism, rheumatoid arthritis, SLE, dermatomyositis, kind of those things. What are those autoinflammatory diseases? Already we had touched upon that finding. Familiar Mediterranean fever. Second one is familiar Hibernian fever. Here in familiar Mediterranean fever, the defect is in pyrin gene. So what pyrin gene does? it actually suppresses the inflammasome, that is the intracellular inflammatory substrate. So whenever there is a defective firing, there is constant stimulation of inflammasome, a cellular component of regulating and releasing cytokines. So here fever happens every 1 to 3 days, and one of the dreaded complications of familial Mediterranean fever is secondary amyloidosis. So in settings we give colchicine because it is a microtubule inhibitor, colchicine as a prevention treatment, and also we can employ because of cytokines release interleukin inhibitors. Second one is familial hibernarian fever. This is of genetic defect in the tumor necrosis factor receptor subunits. Here the intracellular domain of receptor misfolds, means instead of going to cytoplasm it misfolds and gets localized within the cell. So constitutively the cytokines are getting stimulated. So here the periodic fever happens once in 3 weeks, lasts for a week, remites, comes back and leads to lot of complications. Here also the treatment is the basic final common pathway is same, interleukins. So here these interleukin inhibitors are going to be effective for both of these periodic syndromes. Okay. Next, most common fever we see now and then, various labeled as relapsing fevers, biphasic, saddle pattern, all these things are most commonly due to infectious etiologies. Brucella, Kala Ajar, infectious mononucleosis, kind of those things. So whatever that comes to your mind, you can write here. So here you are free, because Einstein already has told, imagination is more important than the knowledge. Here, see, here you can run your imagination wild. Fine? Okay. So now it is clear, isn't it? Broadly there are two types, that's it. Recurrent or continuous. In recurrent, you can discuss as autoimmune, autoinflammatory, intermittent. In continuous, if fever is not touching the baseline according to some others, you can label it as remittent. So remittent is because of, you can remember only one point, infective endocarditis. You shouldn't miss that thing. Second one, sometimes we encounter these intracellular bacteria. In one more interesting variety that I would like to highlight is cyclical neutropenia. Here in granulopysis, that means a generation of WBC, there is a cycle. So every 21 days there is a cycle of production of lymphocytes, neutrophils, kind of those things. Because you know neutrophils are essential for defense against bacteria. Whenever they are at their nadir, means lowest level, fever may happen once in every 3 weeks. So fever happening once in 3 weeks, please remember this thing, cyclic neutropenia, unless proved otherwise. Okay, we will go to next topic, and that is the final one, management of fever. Many of you, especially with the COVID season, you will be hearing a treatment with Dolo. Dolo is nothing but paracetamol. Dolo is the trade name. Why paracetamol has been used so much or even abused is because of its mechanism of action. Abused is because of its mechanism of action. Paracetamol is thought to be quite safe for stomach. It doesn't cause gastric irritation. But if one is consuming paracetamol, especially in the dose of every day, 3 grams or 4 grams, what will happen is that liver gradually gets damaged. So one of the sinister complications of excessive paracetamol dosing is liver damage. So always advise the patients, unless it is required, please don't take any so-called painkillers, including paracetamol. Though paracetamol doesn't typically fall under the spectrum of NSAIDs, because there is always issue of either liver damage or renal damage. So coming back to mechanism of antipyretics, let us discuss about paracetamol. The main mechanism of paracetamol is it inhibits a constitutive enzyme. known as cyclooxygenase. COX means cyclooxygenase. COX. Okay, this is the abbreviation. So what this enzyme does is that it releases the arachidonic acid from the cell membranes for the synthesis of our beautiful prostaglandin E2 that we have discussed earlier. So once this is blocked, there is lesser production of prostaglandin E2. So there is defervescence of fever and also other symptoms like arthralgia, myalgia also will subside. On the other hand, there is one COX3 enzyme because there are multiple cyclooxygenase isoforms. COX1, COX2, COX3. COX1 is constitutionally expressed. COX3 is exclusively localized to brain. Here the beauty of the paracetamol is that it directly acts upon the COX3, especially after it is metabolized in the brain, so that it directly inhibits this COX3. So please remember, for any fever, equally effective are aspirin, paracetamol, ibuprofen. But for safety wise, we are giving paracetamol. On the other hand, aspirin is not recommended for children. Why? Because there is risk of Reye syndrome that we are going to discuss in next few sessions. Those children who unfortunately got in the grand olden days, they died of this Reye syndrome because of aspirin. This is encephalopathy like picture. Of late, we have seen second class. These are known as COX2 inhibitor. Like for joint pains, body pains, many orthopedicians, physicians, rheumatologists used to give COX2 inhibitors, celecoxib, etoricoxib, kind of those things. They said to be gastroprotective, but in long run, actually there was increased risk of cardiac events, means heart attacks, kind of those things. That's why nowadays they are not recommended that much. So currently there are hardly 3 agents that you have to remember for your clinical practice. One is paracetamol, second one is ibuprofen, third one is that I have not mentioned, that is naproxen. The beauty of ibuprofen is, in addition to inhibition of cyclooxygenase, it also decreases the stimulatory effect of interleukin 1 on interleukin 6 production. You know, interleukin 6 is the most potent pyrogen. So ibuprofen has got dual action. That's why in any patient, if fever is not subsiding with paracetamol, we will add ibuprofen. Got the point? This is a very good clinical concept. While discussing this, few of may get the doubt why we have to discuss so much about these things. Fever per se may be troublesome for some time because you know fever per se is not a disease. Fever is a cardinal manifestation of what is the pathophysiology in our body. So when you are treating fever, we have to remember a few things which may pose a danger to the even life also. Like for example, every 1 degree centigrade in the temperature can lead to increased oxygen consumption by 13%. So in an elderly patient who is having any heart problems or respiratory problems or actually physically got decompensated, such things can lead to further deterioration of his health condition. So we treat the patient not only for the sake of fever but also for overall health being. Sometimes just simply because of fever, patient may get deteriorated. So in such settings, we have to use these agents whichever are safe for his conditions and comorbidities. In addition, one of the important things often neglected is degree of water loss with fever. Majority of the patients with fever, they don't eat and they tend to lie down in the bed in almost a fetal position. And one of the common mistakes in our clinical practice is under replacement of water loss. You know, insensible water loss in typical adult is around 1 liter per day. It can be excessive in hot and humid climates, but for each 1 degree centigrade rise of temperature, the water loss is estimated to be 2.5 ml per kg per day. So sometimes what happens is that we will be simply giving this 1 liter, but not giving this extra fluid that patient has lost, half liter. That means mistakenly we might be missing giving extra fluid, means almost 50% of the total fluid that was lost. Please remember this point. That's why judiciously we have to treat this fever with these agents. Coming to end of this discussion, last but not least, most important ones are glucocorticoids. Often we employ these agents in the setting of autoimmune diseases like rheumatoid arthritis, other joint pains, systemic lupus erythematosus, where patient might have got fever, and also autoinflammatory diseases, even some cancers also. But the mechanism of action is slightly different. Because glucocorticoids are labeled as steroids by layman people, similarly we also have to be little bit careful while choosing these agents. They should be given only when patient requires. These are not the drugs to be given as a first line treatment for many of these conditions. So the mechanism of action is, first one is they inhibit this cardinal enzyme phospholipase A2, which is important in the release of arachidonic acid from the cell membrane. Second one is, in addition to these things, cytokines. You know all these prostaglandin E2, cytokines, these are the spectrum that we have got. Here these glucocorticoids act upon the biosynthesis of cytokines. That means at the root cause they are striking. So down the stream there is a decreased production of prostaglandins, which can lead to resolution of fever or other any inflammatory changes. Thank you very much.